tomorrow. When we're talking about simulation and registration of images in SBRT, it's really a very large topic. So in order to conquer, we have to divide. I chose to concentrate today about motion management, and I do promise you, there's nothing to disclose here. I do promise you, and that's a pledge, there will not be any boring physics concepts. Everything we will discuss is applied, applicable, it's of interest to radiation oncologists, physicists, and therapists. Today's lecture in particular, it's going to be more of interest towards CT sim therapists. Tomorrow will include also the CT sim therapist and the LINAC side therapist. So today's lecture, we're talking about methods for motion management and how each affects patient workflow and what you could do to have proper motion management for your patients, even if you have limited capabilities. So this would be towards the end of the lecture. Now, when we say motion management, we basically refer to the internal motion of the organs, right? We're not talking about a patient moving on the table. That's external, and that should be restricted by the immobilization devices. A lot of things move inside the patient, inside everyone actually, and of course, the lung is the most obvious one. We do lung, liver, pancreas, and kidney motion management where I work right now. And the question is, why do we bother, right? Why do we bother with motion management? Well, first of all, you have a better delineation of tumor edges. When something is moving, the shape distorts. In addition, you have a better separation between tumor and organs at rest, because now you know when things are moving, they get blurry. Both reasons could lead you to escalating of dose. So you could go to higher doses per fraction, which is what SBRT is all about. Now I'm going to start with a question. So let's see. Right? It's morning or evening where you guys are. And this is a poll, and I would like everyone to participate. So question number 1, motion management is used for, first choice, all moving tumors regardless of treatment technique. B, all small moving tumors regardless of treatment technique. So the difference between A and B is the size of tumor. C, all tumors treated with SBRT. And finally, just a small tumor is treated with SBRT. So we're going to give you 1 minute and let's see what choices you make. So Ben or Shada, you're going to let me know when the poll is done, correct?
Yes.
Just one moment. I think I need to log in.
Oh. So the first question is not yet ready. That's fine. You're set up, Ben, or not yet?
Not yet, but people are putting it in the chat.
Okay, let me see the chat. So we caught our organizer unprepared. All right, we have most of the answers are A. We have a C. So in fact, motion management is for all moving tumors, regardless of treatment technique you use. And we do, in this institution where I'm working right now, we actually do motion management for 3D planning. Because remember, 3D planning is part of conformal. This is the first step in conformal therapy. And you're trying to conform your high doses to the tumor, even though it's not hypofractionated, it's not SBRT, but you still want to treat your tumor successfully. Here's an example, right? This is a large tumor. Clearly, not a patient for SBRT, or maybe, I don't know, the radiation oncologist can tell us. And here's my question for the physicians in the group, for the dosimetrists, and for everyone actually. Where does your tumor start and end? And I'm not just talking about the sides over here, like the lateral part. I'm also talking about, hold on. I need my pen. All right. So we're not just talking about the inferior part of the tumor. I'm also talking about the medial side. Where does it start? Where does it end? Because if you want to draw the bronchial tree, where would you draw that? So even if this is a 3D CRT case or a conventional case, where is your GTV? Clearly you cannot do that. Look at the difference between free breathing scan, the one to the left side of the presentation of the slide, and a gated scan, or a scan done with 4D CT, and you take 50% phase, for example. Now, definitely you know where the tumor site is, and definitely you can tell the medial portion of the tumor. This is an example taken from AAPM report number 91. Another thing, let's say we have a small tumor, or not necessarily a small tumor, a medium-sized tumor, but it's a spherical in shape. Like most lung tumors tend to be, those are treated with SBRT, right? Now, if you take a perfect sphere and you CT scan it without, a sphere that is moving, so this sphere is put on a platform that is moving in a sinusoidal manner, and you do a helical scan, you will get something like this. And I'm pretty sure a lot of you have seen tumors that, or most likely the diaphragm, in the lung, that you see part of it kind of hanging in the lung in one of the cuts, and then you go one or two cuts without diaphragm, and then you see the diaphragm again. So whether we're talking about small tumors, large tumors, if we CT scan a moving subject without taking motion into account, you will not be able to do proper GTV delineation. So even if this was a 3D CRT case, you will grossly underestimate the volume of the tumor, and hence you'll be under treating your tumor, right? So I'm driving the case here is that motion management is needed, not only for SBRT, but also for your regular 3D CRT patients where we're treating tumors that are moving. So more so now when we're doing hyperfractionation with SBRT, you can understand why we really do need this motion management, right? We cannot, delivering 12 gray per fraction or higher or lower, or we're still delivering a really high dose per fraction. You want to make sure that you're hitting that target, but you also want to make sure that you're delineating the correct target. As of now, there are 5 techniques for motion management. The first one of all is what we call motion encompassing methods. Basically, this is just a 4D CT scan without any further work related to it, meaning I do a 4D CT scan, and then we follow the motion of the tumor in the different phases. And that's what we create something called ITV, internal target volume. Respiratory gating is when you're choosing certain phases of the breathing cycle, and you say, I'm going to plan and treat on those phases only. Breath hold, you could either have a deep inspiration breath hold, where patient takes a deep breath and they hold it, or a deep exhalation breath hold. And here, actually, there are 2 schools of thought. Some people like deep inspiration, others like deep exhalation. And we're going to see why. Maybe it makes sense or is intuitive to think inspiration is the way to go. So like people's lungs are filled with oxygen. So why do I want to have a breath hold when I'm out of oxygen? Doesn't make sense. But I'll show you with data that it's actually better than deep inspiration. And then we have what we call forced shallow breathing. There are 2 methods: chest compression. This is kind of a passive way of forcing the patient to have shallow breaths. Or there is a solution by one of the vendors called the ABC, active breathing control. The last one is very involved, and this is where your radiation treatment is synchronized with the breathing motion. So let's imagine this is your LINAC, and the LINAC would be moving back and forth to follow the breathing of the patient, right? This is basically for cyberknife cases, which we will not discuss today. We're going to go through the entire clinical, practical issues of each motion management technique that we just mentioned, except the cyberknife one. So motion encompassing methods. Most of you are probably doing this or will be implementing it very soon. In fact, if you've bought a CT simulator in the last 10, 15 years, it already comes with this option built in. Motion management starts, or motion capturing, starts with a device that you put on a patient's chest. It could also be a belt that tracks the patient's breathing. And then it gives a signal on the screen and shows you how the breathing pattern is. The expected breathing pattern is a nice sinusoidal wave, assuming patient is a phantom that doesn't move, doesn't cough. Perfect. Then we do a CT scan with different phases. To capture the full phase of the motion, we like to see 10 phases. Someone might ask, and if not, I'm going to ask this on your behalf, why 10 phases? Why not just 4? Why can't we go maximum exhale, maximum inhale, and like 2 points in between? Or just maximum exhale and maximum inhale, and we're done. So remember that the motion is not just up and down. It's not linear. Some tumors, especially in the lung, they could go either a circular motion or they could go a more ellipsoid motion, بيضاوية أو دائرية. So if I don't have enough sampling to capture the lateral and APPA motion, not just the swoop end, you could also be missing locations where the tumor might be at. And I'll show you some examples where we have 6-8 millimeters in post and or right left motion. So now, as we said, we're trying to capture the location of the tumor in every phase the patient is breathing at. And this envelope that captures this motion, that's what we call the ITV, internal target volume. Those are just the solutions that you could find in the market. I will not be marketing any product here. No vendor names, but probably if you're working with it, then you know it. As we said, this is a box you put in a patient's chest. It has reflectors, and then it's seen by infrared camera, and then the camera basically tracks the up and down motion of the box. Or you could have a bellow belt system that you put on the patient that expands and contracts, and it moves as the patient is breathing. So let's spend a little bit of time here and think about this ITV concept, internal target volume. And this concept is a valid concept and is very useful for 3D CRT planning and not much encouraged for the full range when we're talking about SBRT. So I'll give you details later, but let's look at the moving target here. Clearly, you can see the GTV in every phase. You could see it go up and then it goes down. And if you look at it, there is a location where the tumor stays the longest, right? And it's right here. Think about when you're breathing, when your lung is expanding or contracting. Where do you think this location is? Is this maximum inhale? Is it maximum exhale? Or is it somewhere mid-cycle? This is an actual patient, by the way. And then the range from most soup to most inf location of the tumor is a 4 cm. So if you look at it, it stays the longest at the most inf. And that's when the lung is contracted. It has the shortest or smallest volume. Basically, that's your exhale. And this is the 50% phase in the breathing cycle. When you look at the sinusoidal wave, this is represented by phase 50%. I want you also to look at the motion artifact. So look, when the tumor is in the most superior phase, there's less artifact. And you can see the artifact by the dome of the diaphragm. And as the tumor goes down, as we expand, as we inhale, you take this deep breath, you start seeing a lot of artifacts. And the question is why? Right? The reason is every time we exhale until there's no more oxygen in our lungs. It's almost the same level of exhalation. You exhale until you're done. There's nothing else to blow out. However, every time we inhale, it depends on our status. It depends if I'm stressed out. Maybe something just scared me a minute ago, or I'm short of breath because I'm speaking very quickly. We inhale to different levels. So exhale is consistent. And this is when also you spend more time at exhale. You actually take a break between you finish blowing out all the oxygen in your lung and then before you breathe in again. So the exhale is the most stable of the breathing cycle, and that's phase 50%. Now, this might explain in your mind, for those who are already doing motion management, why 50% phase is considered the reference phase. It is where the tumor spends the longest. It has the least motion artifacts. Okay, I thought someone was asking a question, right? Okay, so now if we have we were able to track.
Hi, Shada, how are you? Yeah, I'm Soha. How are you?
Ahlan, hala, Soha.
Hello. This is particularly for the lung or any moving organ to have the phase 50%.
50% is the most stable phase for any moving organ. Now remember, most of the motion in our body is actually because of the diaphragm. So the liver, the kidneys, pancreas are also being pushed down because of the diaphragm motion. And the diaphragm is most stable when we have the maximum exhale.
Okay, thank you.
You're welcome. All right, so now if we're talking about lung, then we do this ITV, as we just showed you, and we add 5 millimeter to it, and that's our PTV, right? And if we're using ITV-based motion management, so just the envelope where the tumor is moving, we add 5 millimeter to it, and then go ahead, let's treat. On the Linux side, there's nothing special. The therapists don't feel anything extra or have to do anything extra, and the patient doesn't feel anything special about that, right? Now, the example I showed you was really extreme, where you have a 4 cm motion of tumor. I've probably only seen that once in this example only, in this patient only. So clearly 4 cm is way too much of a range of motion. And what we want to do, we want to make it smaller, right? Because if you want to have higher doses per fraction, hypofractionation, we want to escalate dose of the tumor and save dose to organs at risk. And we have to have a very sharp gradient. 4 cm of motion will not cut it. And actually the RTOGs do not recommend anything beyond a certain motion range. And we'll keep that as a secret for the next few slides. Before I proceed, someone might ask, where did the CTV go, right? I just put in PTV equals, basically is GTV. ITV is the different GTV at different locations, plus 5 millimeter. For RTOGs, there is no margin to account for microscopic extension. What you see on the CT sim, the abnormalities you see on the CT sim, again, this is specific for lung tumor. This is what you contour. This is your ITV, and then you expand to get the PTV. So there's no enlargement whatsoever for any inclusion of microscopic diseases. Normal CT plus margin is your PTV. So basically GTV is CTV, in case someone was wondering. Now, as I said, RTOG does not use the concept of full range ITV as a motion management. What they look for is either gating, breath hold. And notice how breath hold here doesn't indicate maximum inhalation or maximum exhalation, as long as it's breath hold. You could also use ABC, respiratory tracking, or abdominal compression. The idea here is that we're trying to limit motion range of tumor to 5 millimeter or less. If your tumor is moving 5 millimeter or less, it's considered good to go for SBRT treatment. If it's not, if it's 4 cm or 12 millimeters or 15 millimeters, sometimes we see, 50 millimeters is more common than any higher number. Then you need to do what we call motion control. And this is the things that are suggested by RTOG. You have gating, breath hold, chest compression, or tracking. So now the next level, let's talk about respiratory gating. So again, I want to iterate, the concept of ITV can be used as is for 3D CRT plans. If you want to use ITV, you have to make sure that the max to min tumor motion is less than 5 millimeter. If it's 5 millimeter or less, I can use the ITV as is for SBRT. If it's not 5 millimeter or less, then we have to start doing other things. We have to control the motion. Next step I would like to talk about is respiratory gating. This is a very involved technique. It's very involved in terms of patient physics time, therapist time on both the CT SIM and also on the LINAC. And it requires a lot of patient cooperation and coaching. So there is a selection for patient criteria. The physicians, they have to know if the patient is a candidate for respiratory gating or not. And we'll go through that in a minute. So again, respiratory gating starts with a 4D CT scan, right? We need to see the tumor moving, first of all, before we say, is it moving 5 millimeter or less? We do a full phase scan, meaning 10 phases, to capture any motion that is not up and down motion. And then we take the 50% as our baseline, and we just explain 50% has the least artifacts. In fact, if the 50% phase shows a lot of artifacts, you need to rescan. First of all, you have to coach the patient again, and then you have to rescan. Do not use 50% if there is motion artifact. And you can easily look at motion artifacts if you look at the digital cut. It's very obvious in the sagittal cut. All right, so we have the phases. You can look at this upper part here. This is where the phase is indicated. This is 50%. And then you draw the tumor. So this is what the physicist is doing. This is what we're going to call the motion study now. So you delineate the tumor in all 3 dimensions. And yes, this patient has multiple lung tumors. I think he had 6 in total, 3 large ones and 3 smaller ones. It's an interesting case that took a lot of time on motion study. So let's choose this tumor. So we're delineating this tumor in coronal, sagittal, and transverse at the 50%. And we will use the location of this tumor in the 50% to measure from it how much shift we have in the different phases. Shifts could be up, down, right, left, or APP. So I'm going to loop now through the different phases, and I'm sorry because of patient confidentiality and different issues in the place where I work at, I cannot even export the patient anonymously. So I had to take screenshots, and then I'm doing this as an animation. So right now, there is, well, you're seeing 80% right now, and you can see motion artifacts here for 80%. Clearly, no person looks like this. There are no blocks coming out of a patient. So those are due to motion artifacts. And you can see this discontinuity in the diaphragm dome. And also you can see this continuity in the tumor over here. This is due to artifacts because of motion. If you see this on the 50% scan, you need to rescan the patient again. All right, so we're starting with 0%. So this is 0%. And I'm going to flip through the animation, and you could see the tumor go up and down. While you're looking at the tumor, also keep an eye on the artifacts. The further away from the further away from 50% we go, the more artifacts we have. So 30, 20, 10, look at 0, a little bit of artifacts. You could have here, but the diaphragm looks intact so far. This is 10, 20, 30. Now we're coming closer to 50%. Things look better. And that's our 50, 60, 70. We're starting to see a little bit more, blocks. So that's the idea. We're going from 50%, scrolling through the different phases. And what you want to be writing down is this, basically. Yeah. So you're doing soup, anterior and posterior, left and right motion. This tumor is too big and it's partly attached to the chest wall. So it's not moving too much sideways, but you could have tumors that move sideways. So the physicists are doing a motion study. What they're trying to do is fill this table. So this is a table that we use at our institution. You could develop something similar to it. And we're doing let's say, that's a different patient, I think. And so and you could tell this is a very recent one as well, just a few weeks ago. So you have, for example, this patient has 2 lesions in the lung, in the right lung, one medial, one lateral. And we have a maximum motion of about 11 millimeters. That's a a good 1 cm in the soup N in the 0% phase. And the right-left phase, we have, let's say, a maximum of 2.6 millimeter tumor motion in the left side, and so on and so forth. Like for the other tumor, the lateral tumor, we have a motion towards the right, which means that the tumor has shifted 1.5 millimeter or 1.8 millimeter to the right with respect to the 50% phase. So now what do we do? Oh, no, it's not LLL. This is RLL in the same lobe as RLL. That's just a mistake from my side. So the physicist would assess the motion of the tumor and then suggest phase gating. So one tumor would require gating between 20 to 70%. So it take 20% all the way to 70%. And we use this for treatment planning and actual treatment of the patient. These phases were chosen because those are the phases where the tumor is moving 5 millimeter or less. So we're excluding 0, 10, 80, and 90. And if you remember, 50% is the maximum exhale. So basically, we're removing the phases towards the maximum inhale. And as we said before, when we're inhaling, we're not inhaling to the same level every time. So you do see a lot of artifacts. Also, when you're inhaling, the lung is expanding the most, and also the tumor motion would be the most. So it makes sense when you do have a moving tumor, you're excluding those sides around the maximum inhale. The other tumor, however, the maximum motion we have is 4.5 millimeter in the inferior side. So all these numbers are in millimeters. And because the entire motion of the tumor is less than 5 millimeter, then we say this tumor doesn't need to be gated. What we do in this case, then we take the ITV and we use it for treatment, for planning and treatment. And this is still within the RTOG guidance, right? It is less than 5 millimeter. So I can then create the ITV, as we mentioned before, from the full phases. And this is what is being pushed to the planning system. Now here's a question.
Shada,
when does
the last sentences that you said, I didn't understand it well. Would you please repeat it again? I was okay when we are going to consider with the 50% the maximum exhale, because this is the most relaxing and clear without any artifacts in the tumor. So when we will consider the maximum inspiration, I didn't catch this.
Okay, so we said if the tumor motion in all phases from 0 to 90% is 5 millimeter or less, then we take the ITV without any gating. But you don't need to gate. The entire phases when the patient is breathing on their own without any other management, then the motion of the tumor is 5 millimeter or less. In this case, you take the ITV, which is the GTV composed of the different phases from 0 all the way to 90. And you don't have to worry about doing anything else to the patient. It is when the tumor is moving more than 5 millimeters, then we have to exclude these phases from the ITV, from the planning. And as I said, you should expect that the phases around maximum inhale are the phases with the largest motion of tumor.
And Dr. Ramahi, sorry to interrupt, but there's a question. What is the phase error in the table? If you could clarify.
Oh, yes. So that is on the next slide, in the next 2 slides. That's a good point. And I will come to it in two slides. So now there's another example where there is close to 13 millimeter motion in the posterior direction, right? And this patient was selected for motion management by the physician, sent to the CT simulator, physicist is available. And what happened is that because of health issues with the patient, they were not able to keep a steady breathing. They were breathing all over the place. And you could see here we have phase error, as someone mentioned, good catch or good concentration on the tables. We have phases error in the 13% over here, and we don't want to see that. What does that mean? It tells me that the quality of the scan is bad, and that's coming in the next slides. So patient cannot keep a regular breathing every time they're breathing differently. So it's taking very long on the CT sim. Sometimes they take a deep breath, sometimes a smaller breath. Sometimes they take a consistent breaths in terms of the volume, but the duration is faster. They go, and then sometimes you go, all over the place. For this patient, it just cannot keep a steady volume or a steady rhythm of breathing. What we did, of course, we stopped the scan. 50% phase was completely wrong. It was very blotchy, very artifacty, if that's a word. We stopped the scan, went inside the room, tried to coach the patient again. And some companies would give you an option where you could have an audio coach. So you go breathe in, breathe out, and then you could also adjust the time. Even with that, the patient wasn't able at all to follow the prompt. So even though the numbers give you something, the numbers were able to, there's some images, we're able to get numbers from the images. And according to those images and numbers, we need to gate, right? However, the patient is not a good candidate. And we made that decision during CT SIM. If the patient cannot breathe properly and consistently for a 15-minute CT simulation appointment, do you expect him or her to breathe properly and consistently for treatment? So the physicists in this case did the study as expected, and then they put in the recommendation here. The recommendation is that we don't treat this patient with phase gating, so don't use gating. And then we try to look for other options like chest compression. Let's try to push the patient chest wall a little bit. When you're putting the chest compression, you're putting it on the abdomen beneath the diaphragm. And so you're restricting the expansion of the diaphragm. That should hold the breathing a little. Deep inspiration, breath hold, and chest compression for this particular patient could not be applied. And hence, the final decision was, well, we cannot treat this patient with SBRT, and we move them to 3D CRT. It reaches a moment where you have to go, what are we doing to the patient? Are we torturing them? Is it worth the trouble, the time? And yet we're not going to get good treatment quality because the patient cannot at all tolerate or follow prompt for regular breathing versus clinical management. And that's really a physician's decision. However, the input of the physicist has to be taken into consideration. I cannot do a motion study on this patient. For whatever reason, we cannot compress his abdomen, cannot tolerate it, he cannot take a breath hold. So then you let us know, you let the physician know, and then they ultimately make the clinical decision. So now we're talking about phase error, and we're talking about what is a good 4D CT scan. So think about it this way. You're capturing the movement, the breathing movement of the patient. There is a moment where the computer is learning the cycle of, the magnitude and the phases. This is pure mathematics, right? It's a sinusoidal wave. And I just happen to choose a perfect patient. What you're seeing here is something you would probably see 1 in every 100 patients that you do motion management on. If the computer can predict the breathing cycle, the maximum, the minimum, and also the not just the magnitude, also the phases, and the prediction are the white dots. This is the computer prediction. The solid line, the green and red solid line, this is the actual breathing of the patient. If the computer can predict the breathing cycle, the wave, then we have very minimal phase error. Now, what happens if you have a large phase error? Basically, you see this one here is blue, right? So this is actually phase 0. What is this telling me? And phase 0 is, I don't have the numbers here, okay, but they're all like 4%, 3%. So when the computer is stacking the different CT phases, so I have a CT scan, maximum inhale, CT scan at 10% breathing, CT scan at 20% breathing, so on and so forth. And now the computer is going to stack them according to its mathematical formula. So all those guys are phase 0. And if they correlate to phase 0 with the patient, with the wave, then I have a very small phase error. If we don't have a regular breathing from the patient, the pattern is not regular. What the computer interprets as phase 0 could be phase 12. So I'm shifted by 12%, right? And it could also be shifted to the other way. What could be phase 0 could be like 88, shifted 12% on the other side. Phase error in this example lets me know how well the computer can correlate the different phases that is going to stack up from the CT scan to the actual breathing pattern of the patient. The minimum, the phase error, the best the correlation, and the least artifact we have. So this is actually a textbook representation of motion management. And it, honestly, when I saw this, there's like one patient out of 100 where we have this perfect correlation. Usually you have 8%, 10%, and then you have to go in manually and adjust and let the computer know, no, let's move this up a little bit here or down. It takes a lot of time because most patients do not really breathe this nicely and this well. Now, clearly, if the patient cannot keep a regular breath, as we said, then they're not good candidates for gating. And this is something that the physicist and the physician both have to make a decision for. It goes without saying that the phase gating, or what we call gating, we say we're doing gated treatment, it is the most involved in the quality assurance for motion management. When the linac is on and off, it assumes that the patient has reached this window where we're gating. And that's when the window starts beam on. And when the patient or the breathing leaves the window, then beam is off. If you have a phase shift, if you have phase error, you could start beam on over here and beam off over here, right? So your beam on is not correlated to your tumor. Or vice versa. You could start beam on in the middle of the window and beam off outside the window. And you don't know that if you don't do proper QA, or if your patient is breathing all over the places. And sometimes, you have good quality assurance, but the patient just breathes out of ordinary. They coughed, or they were a little bit tense, and then they got relaxed for whatever reason. You're throwing off the entire algorithm. So phase gating has a lot of consideration that goes into it. First, you start by good choice of patients. Patients have to be proper for gating. They need to be able to breathe in a cyclic manner. And you have to spend time on the CT simulation. You have to coach them before they go in. Usually the initial coaching is done by the physician, or if your department has a nurse coordinator. I've worked in a department where they have nurse coordinators. Nurse educators. So the nurse educator would spend time with different patients according to what they're going to go for treatment. And part of their work is educating the patients who will have motion management done on them. So this is the first, or in coaching or training. Usually it's like a week before or 2 weeks before CT SIM, depending when the patient comes in for the clinic. And then on the CT simulation appointment, they have a good 1 hour schedule. And it starts with the CT SIM therapist talking with the patient, and do you understand what we're going to do? We try to ask you to breathe normally, no sudden moves, try to keep and maintain a nice rhythm of breathing. And actually, once you start talking to patients like this, they start forcing themselves to do like a yoga style breathe, right? Go like, no. Breathe normally. Just be mindful that you don't do anything that is sudden. Or you take quick breaths, or you take longer breaths, and then then they're put on the couch. They have whatever, the bellow belt, or they have the box on the chest, and then you need to keep them sitting there and watch them. because when you first set up the patient, you put them in this position and they're under, it's especially if this is the first time they do a CT sim, they're apprehensive, and they're stressed, they don't know what's going on. So you need to give them time to relax so their muscles relax. And then they take a more natural position. All the while, the physicist is noticing the breathing on the TV screen, on the screen. So it does take a lot of time. You have to observe, you have to coach the patient, you have to train them, you have to observe them. And before we take the scan, you need to let them know that couch is moving, because they've been sitting on the couch for 5-10 minutes and you're just looking at them, and all of a sudden the couch starts moving. They would freak out, right? So you should let them know in 1 minute, the couch would move. You're doing fine. Keep on doing what you're doing. And then, of course, after the CT scan, the physicists start the motion study. Now, I unfortunately have observed physicists who let the therapist do the motion study on their behalf, or they sent residents. And I've told my residents, no, don't go alone. You need to take a physicist with you, the staff physicist. They say, you know the routine, put the thing on the patient, do the 4D CT scan, and then let me know when the images are ready so I can do the study. Now, if the physicist wasn't there during the motion study, and you just look at numbers, you could actually give an analysis, but this will not be practical for patient treatment. The computer will give you an output. If you guys know this concept from computer science, it's called, GECKO, garbage in, garbage out, right? You'll get numbers, but if you have to be there to see how the patient is performing, if you need to stop scan and go inside the room, coach the patient again, maybe they're fearful, maybe they're not relaxed for whatever reason. Perhaps it's time to put in the audio coach, the breathe in, breathe out coaching that they hear. You have to make sure that you have given this patient all the possibilities, all the chance they can get to have a good scan. And again, I have here the quality of breathing pattern depends on patient willingness and cooperation, but actually also it depends on the patient health status, which, I should also mention in the slide, it goes without saying. They cannot keep a normal breathing pattern for whatever reason, then you, the physicist, and the radiation oncologist, what you have in the department, what other things you can offer. We can do chest compression, you can do DIBH, etc., and try to do that for the patient. I have seen motion studies that would go into 2 hours on the CT sim. So we cannot do 4D CT, we cannot do a DIBH. Let's start chest compression. And everyone needs just to be relaxed. And I know the CT sim therapists will be pulling their hair if they have hair. Most of the time, CT sim therapists actually have no hair because of things they see. But you need to give this patient every possible, technique you have in the department to assure that you can deliver SBRT. If you cannot manage tumor motion that is more than 5 millimeter, then the recommendation is not to deliver SBRT, which could change the entire management from curative to palliation, or could mean more toxicity to the patient. So you have to make sure that there is enough time and that patients you send to motion management are well selected. And if not, be ready to have other options available that you can also implement. So in the institution where I work at, physicists have different tasks over the month. And for the physicist who is tasked to do motion management, that's the only thing they do for that month. Because that physicist could be basically in the CT sim all day. We're doing 4 to 5 motion managements a day, which could take an entire CT simulation work schedule. We have 2 CT sims, so don't worry about that. We have another CT sim to carry the regular load of the department. All right,
Shada?
Ben, are you? Yes.
Maybe we can pause, and I think we have some questions that are coming up. But if you can go back a couple slides to the one with the blue chart.
The blue chart, this one.
Yes. So I think the slide is familiar for those who are using SBRT, but for those who haven't done it, I think maybe you can explain in Arabic, like what phase means. I sort of wrote that It's describing from 0% to 50% to 100% the part of breathing, the phase where we're trying to get from 0, starting at inhaling. We exhale,
yes,
and we go up to 50, and then we inhale again, and we get back to 60, 70, 80, 90, 100. And 100, we basically start over, and now we're at 0.
All right, hold on.
That's hard in English. Maybe you can say it in Arabic.
Sorry about this. I clicked too many times and it took me all the way to the beginning. Okay. This is the best representation I can show you of phase. Phase equals location of tumor at this time. Mathematically and physics speaking, for the physicists in the group or the mathematical geeks, I know many radiation oncologists love math for whatever reason. When we plot the breathing cycle, it's a sinusoidal wave. عمودي تماما بنقول 90 درجة. الدرجات هي الphases. So 90 degree, phases are different locations on a circle. In terms of motion management, phase 0 is this bottom part here, is when the tumor is at maximum inspiration. Phase 50% is when the tumor is up here at maximum exhalation. يعني فكر بالفيز أو فكري بالفيز، فكروا بالفيز. The highest part, this is 50% phase، هو الشهيق، الماكسيمم شهيق. وما بينهما تتوزع الphases. So phase equals different location on the breathing cycle. That's the easiest. Like this example, for example, right? Let's start from here. Look at this. I don't know. I think you can see it. It says phase 0%. And this is how the location of the tumor is, or where. And now I go phase 10%. Look at the phase change. Now the tumor changed location. And this is phase 20%, 30%, 50%. And we go 60. So sorry, the image, the scan goes up and down because those are just screenshots and I didn't overlay them properly. But phase is relating to the location of a tumor at time A. Okay, so at time A, this is the location of the tumor, 11 millimeter in the inferior direction. At time B, we'll call it phase 10%, location of the tumor is 5.9 millimeter in the inferior direction. نسبة لشو؟ نسبة to 50% phase. So 50% phase is our reference. تمام؟ But all these motion نسبة إلى phase 50%. اللي إحنا قلنا 50% هو الزفير الكامل. And this is for people who like to see figures and diagrams. I learned صراحة by looking at figures and diagrams. 50 phase or phases represent different locations in the breathing cycle. الإنسان بيتنفس the lowest point on the curve. Different locations على so phase equal tumor location, phase equal a breathing moment of time. ما أعرف quite يعني is it clear?
Thank you so much for that. And there's also a couple more questions.
Sure.
If I could. They're asking if there's any slide of your setup and accessories that you use for your patients.
Well, this is tomorrow's lecture.
All right.
So today is all about motion management because we have to focus a lot about it. And I want to show how motion management will affect your workflow, your patient workflow, etc. Oops, hold on. And I think I burned my question, right? I put the correct answer is C. I forgot to remove the question. Tomorrow we'll talk about the different different patient immobilization and بالhidden neck mask, بالspine, if you're doing prostate, إلى آخره. So tomorrow is more also practical about immobilization. It's very therapy/physician/physicist بهالترتيب هذا.
Thank you so much.
Ben, no problem. Ben, no need to put any poll here. The question is already answered. So the question says, treatment based on gating is the only recommended motion management technique? Clearly not. It has a longer setup time, but faster delivery. Absolutely not. Gating has also the longest delivery time on the Linux. So you have to put a lot of Linux time. I get this. And then it requires special tools in the CT SIM and Linux room. That is correct. It does require special tools. Whatever you're using for the patient in the CT SIM room, you have to use it also for the Linux room. على فكرة, where you put this block that captures the motion, if you put it a little bit higher or if you put it a little bit lower, the signal you get will be different. If I'm doing gating, phase-based gating, that shouldn't be a problem. If I'm doing DIBH, that could be completely wrong. Okay, ممكن نحكي بالتفاصيل. So, to the degree that you have to take note where this block is placed on the patient. And that's also going to figure out in tomorrow as well. So whenever you put the block or you put the below, if you're treating with below belts or with the block, you have to document where on the patient that was put.
Awesome. I'm going to end the poll. We have about 50% of participants who...
The answer is already on the screen. I forgot to highlight.
And some people already chose one on A
Which
and
is
B.
good.
Yeah.
Oh.
They're not looking at the answer, maybe.
I appreciate their honesty. Yeah. Unfortunately, I forgot to hide the answer on the screen.
And then I want to make one more point in case people missed it. Using 4D CT captures all the phases of breathing, and you can do your treatment plan using all of that. Using respiratory gating is choosing just one part of the breathing cycle that you're going to focus on. And so that's a different thing that's more advanced. And as Shada says in this, that requires special tools in the room and maybe more advanced software. So don't get that confused. Gating is a more advanced thing.
Yes, thank you for the explanation, Ben. And even for breath hold, we're going to see it's not also easy to do. So breath hold, whether it's maximum شهيق الكامل أو الزفير الكامل, whether it's deep inspiration or deep exhalation. What you're doing here, you want to ask the patient to hold their breath. How about let's do this test. How about you guys عملوا الزفير and hold your breath. Let's see how long you can do that. So exhale and hold your breath. While you're doing that, notice if your back is arched. Now let's do another test. Let's do shahiq, maximum or deep inspiration, and hold your breath. At least for me, my back arcs. In the exhalation part, it's more relaxed. So depending on which breath hold you're using, you can have different problems in patient immobilization. And you have to teach the patient. So if you're going to go with DIBH, deep inspiration breath hold, you have to teach the patient to take the breathing in without arcing their back, without doing this, right? And like relax, right? There's a lot of coaching. Even for breath hold, there's a lot of coaching as well. So when we're talking about breath hold, we still have this box or the below belt, depending on what you guys want to use. And you also need to do practice run with the patient. And when we do the practice run, we have the patient sleeping on the table couch, on the CT couch, right? Because we want them to do the practice in the same position we want to scan them. And this is where we notice if they're arcing their back. Let's say we're doing the IBH. So we go inside, patient on the table, we put them in whatever immobilization device you have. We'll talk about that tomorrow. And then you'd say, okay, we want you to take a deep breath without stressing yourself. But you're also watching the patient. And then you have a clock time. We're trying to go for a minimum of 20 seconds. Reason is 20 seconds is the time that you need, minimum time you need to do a CT scan. So if they cannot hold their breath for 20 seconds, it's meaningless. If we cannot hold the breath for 20 seconds, then, do you think they're going to hold it long enough for the treatment to be delivered? And of course, the question is, of course not. And what are we looking at here? So first of all, you're looking at, hold on. You're looking at when the patient takes a deep breath and you see there's, you take a deep breath and you hold it, you can actually feel, if you do it right now, if you practice where you guys are, and you can actually see this on the screen. So there is a slight hump, and then we have this constant breath hold. And we want to make sure that it's 20 seconds. And also we want to make sure that we are within a 5 millimeter window. There is a reason, the 5 millimeter window, we're allowing the patient to breathe differently by 5 millimeter each day. We don't want things to be more. Don't go with a 7 millimeter window. Don't go with a 1 cm window. That is, the larger the window you have, it means I have larger variation in the lung volume from day to day. So we will not be aligning properly. So you create a 5 millimeter window, and that would be the window that inside of which the beam will be on. And this is the window also when we do the CT scan. Now, you notice when you do this a couple of times, the patient runs out of breath. And it's most likely it's very cold, etc. You're going to get exhausted. And that's actually what you see. And this is captured. You see the patient is breathing very regularly. So you need to give your patient time to relax. So even for breath hold, the CT SIM time is a good 1 hour. So 1 hour is actually good to do any motion management you want. We seldomly go above 1 hour unless the patient requires, multiple coaching, multiple sessions. Now, finally, what you want to tell the patient is that, now we're going to CT. Someone ask a question?
No, I believe that was just an unmute participant.
So when you do the CT scan, you want to make sure that the patient is holding their breath properly. They are within the window. The dark blue here indicates when we did the CT scan. So this is the same patient, by the way. So we started for a first time CT scan, but the patient wasn't able to hold it enough for us to finish the scan. Once they went below the level, CT scan stopped. And then you have to go inside and you coach them. Your patient. And if you notice that the patient can understand, they're educated, they're conscious, they can understand when you talk to them. Have the patient on your side. Let the patient know what you're trying to achieve so they can help you. Once you talk to them, this is what we're trying to do. And this is how it's affecting your treatment. You'll find that they're more cooperative. So we got this very nice scan afterwards, and you can see the patient was able to keep it held for very long time. Now, if you do breath hold, al umyani, meaning you don't have any feedback circuit for the patient. One day they'll be breathing in very deep, and one day they're breathing in a little bit, or they could be breathing in and out. You're بتنفس شوية صغيرة, you're breathing out a little bit, but you're thinking you're not. شوي أنفك بنفس. So this shows a patient, the patient that I just showed you, with the feedback. And we had this patient, unfortunately, we had a regular phone that we connect to the network and that can display the screen. That phone on that particular day was one of the CT SIM therapists who did not show up for work. So we did not have the feedback for the patient. And you could definitely, and we thought we could do it, but you could see how it's really different. And we ended up canceling the appointment for the patient until the patient is back. We could have the screen back. So it's good to have a feedback for the patient.
Sorry, Dr. Mahi, there's a question. Is the chart that you were on, they're asking about whether it was surface imaging?
No, not surface. This is from so let me show you what we have. In the institution I work at right now, we have the Varian RPM solution. I'm sorry, it has to go through the entire loop. So we covered a lot today.
Yeah, it's been very, very informative.
So what we have is this solution. It's called the RPM. Usually it's sold with the Varian Linux, but you can buy it even if you don't have a Varian Linux. and it comes with its own software. And you have to connect it to both your CT sim. So there is, when it takes the wave, the breathing wave, and the computer analyzes the different phases, then you push them to the CT simulation software, whatever that is. And then you should have the same solution on your Linux. This is by no means the only solution in the market, but this is what we have. So the waveform I was showing you is from this software.
Great. Thank you so much. And while you're going forward, I'm going to ask one more question. Sure. If there's any threshold variation between the CT sim and treatment console where the patient is not able to duplicate the same pattern that they had for CT sim, and how do you manage such cases?
Oh, yes, we have a lot of variations. And we see them more often when we don't have a feedback screen. So on one machine, we have a screen that patients can look at, and then they can breathe and say, okay, so this is what you did during CT simulation. We want you to breathe in at the same level. And unfortunately, on another machine, we don't have this option. So we try to have all the patients scheduled on the machine where we have the feedback circuit or the feedback screen. However, that's not the case all the time. So what do we do? If the patient has to breathe in a little bit above or lower, then it means we have to change this window, right? Now, we don't open the window. We keep it 5 millimeter, but then we move it up or down. Question is, how much up or how much down? So what happens, patient breathes in, they don't reach the target window here, as they did during CT sim. The therapist on the Linux tell them to breathe a little bit more or a little bit less as they do another cone beam CT around the patient. But if the patient is consistent, let's say breathing higher or lower than they've been doing in the CT sim, then we the therapist call in the physics and the radiation oncologist. And we look at the CBCT images and we try to do the comparison with the CT simulation images. If it's reasonable, meaning we can get the tumor to where it's supposed to be, we can align both images to the tumor, and there is not much difference in the location of the normal tissue. The lung is maybe a little bit more or less in volume, but not much of a difference. And if it's a chest wall, near a chest wall, tumor near a chest wall, or tumor near the midline, that we're still getting. I'm sorry. Can you guys hear me? I think I lost.
Yes, we can hear you fine, Dr. Ramahi.
My phone just, sorry about this.
No worries.
هلا السؤال, how much is good enough? If you change this window, the center of this window, it has to be done with the approval of the physics and the approval of the radiation oncologist. And what we're trying to decide here is the CBCT images with this different window, is it good enough to treat based on the CT simulation planning? Now, as I said, if you need to change it, we change the center of the window, up window. We keep the width 5 millimeters. So you're still allowing the patient to have a 5 millimeter variation from day to day. So you just take the entire window up or you take the entire window down. If, however, you notice that if we're matching to the tumor, then and the lung volume is different, or the location to the chest wall is different, and then you cannot treat, then either you have to change to the machine where we have the visual feedback, or unfortunately you have to re-CT sim a patient. I think we only had to re-CT sim once. We had to change patient from one machine to the other, maybe a couple of times, to the other machine where we have the visual feedback. Most of the time, a small change in the location of the window was good enough, but then the assessment has to be by the physician. Is the new volume of lung too different or still similar to what we did the planning on? And that's, eventually that's a clinical decision. So as I said, we do breath hold for variety of variety of sites. And if you remember, I think in the second or third lecture presentation, someone mentioned they don't do the IBH for lung. And in fact, in our institution, one physician sometimes does the IBH for lung, and the question is when. And I asked him to write me a small paragraph about, when does he consider the IBH for lung? And this is what he sent to me. So if he looks at the gating window is too small, too narrow. We're only doing 40, 50, and 60% gating, meaning the tumor is moving more than 5 millimeter above this window, and it's moving 5 millimeter or less here. Remember, this is just 40, 50, 60. So really a very small gating window. A small gating window means that you have a lot of time. Hold on, my daughter is here. You have going to spend a long time on the LINAC to treat the patient. The patient will spend more time not being treated than treated. So in this case, the physician told me that they will consider DIBH. You could also consider DIBH if you want to reduce the reduce the chest wall dose. You want to have maximum separation between wherever the tumor is and the chest wall. And that, again, it's a clinical decision. Like, as a physicist, I wouldn't know if this case is good for DIBH or not. The second one, definitely I can tell you if it's a narrow gating window, then I go to the physician and I say, this patient has a narrow window, do you want to go to DIBH? So for this particular physician, whenever we have a motion management for his patients, we have to do the motion study on the CT SIM room, and the patient is still on the couch waiting for us. And if we see a narrow gated phase, then we call him, and then he makes a decision on the spot, does he want to go to DIBH or not? And then we have to switch again to a DIBH method of management and rescan the patient. Just for this patient, a physician alone. Other physicians, that's fine with them. If it's a very small, narrow window, they don't mind. So DIBH could be used for lung, depending on the school of thought of the radiation oncologist to work with. Other recommended motion management that we just talked about, maybe in passing, is chest compression. It's when you have some device compressing the abdomen beneath the diaphragm of the patient. What you're trying to do is restricting the expansion of the diaphragm with the hope that it also reduces the motion. You have to do a scan, and then you have to make sure that the diaphragm is, that the motion is 5 millimeter or less. This is a very quick scan because it requires a helical scan. However, another school of thought, we have two physicians who also do a 4D CT phase scan with chest compression. So we do a chest compression, narrow, let's say 2 millimeter, 2.5 millimeter scan, and we're done. And then we do another 4D CT with the chest compression. What those two doctors like to see, they want us to do motion study to verify that with the chest compression, we're seeing a motion of 5 millimeter or less. So they want to see with their own eyes. They want us to submit numbers. Again, that's a school of thought. Other physicians would just go with chest compression and then don't bother with anything else. Active breathing control is sold by a vendor. It's a form of shallow breathing. So you're forcing the patient to breathe shallow and also with a slow rhythm. يعني الجهاز بيسكر أنف الpatient. I haven't used it, to tell you the truth, but I've heard people who've used it. I've asked the therapists. We have therapists from different places who are working where I work right now. They've worked in different places with ABC. And they told me that the patients were always complaining. They feel they're suffocating because they cannot breathe on their own, and then they're only getting like a short breaths. كمية هواء قليلة فبيحسوا حالهم مخنوقين. Definitely, if you want to go with the ABC solution, you have to sit down with the patient, you have to coach them, you have to train them, you have to tell them what to expect. Because if you kind of hook up the patient directly with the device, of course they're going to panic. So maybe you can have a dry run during CT SIM, or even in the clinic, if you have a educator nurse or with a nurse coordinator, you can book time in the clinic, get the device, and have the patient feel how it feels to be connected to this device. So the first time they experience it is not on the CT SIM couch. Okay, so we're already beyond an hour and 15 minutes. And because we have another lecture tomorrow, we're not going to go into details. The quality assurance for the different motion management devices you have Depends on what you have, of course. Those could be done, maybe, I don't know, we can ask Ben either a separate lecture or, I don't know, we can send questions, etc. Chest compression doesn't require much QA. Actually, there's no QA to it. The only thing that you need to always, whatever device you have, from the CT SIM documentation, you have to document where the device is. So I'm compressing this part of the chest. Don't assume people will say, oh, well, midline, واضح إنه midline. No, you have to either delineate it on the patient's skin, by tattoos, by some marks, and you put Tikadder on them so that they don't remove, etc. Or you can write something, adjacent to the midline and adjacent to the diaphragm, or just touching the xiphoid, whatever you guys want to write down. But it has to be documented, and that's true for everything else you use, not just for the chest compression. DIBH.
Sorry, quick question. Sorry. Quick question about the chest compression. Where will you place the 6-dot box on the body? Do you have
on the lung. So the chest is compressing the abdomen below the diaphragm. This is our practice, at least. Other people might choose different. So we put it's right below the diaphragm. So it's restricting the motion of the diaphragm. And then we put the reflector box on the lung, on the chest. Clearly, I cannot put it on the compression device because it's not going to move. It's, you're فعليا عم بتعصل المريض. Patient cannot move there. And let me tell you, from practice, it was going to be very hard to pick up any motion on the device because patient is barely breathing. But which is good. If I cannot pick up any motion on the device, definitely I'm less than 5 millimeter. So probably just pick up small, tiny motion. And an idea of doing 4D CT with chest compression, just to verify for the physician or for you, the physicist, that the tumor is moving 5 millimeter or less. So, put it on the chest wall wherever you can see any motion. It gets difficult if you have a female patient with big breasts, because then the device cannot stay, in one place. And so if you cannot do it, you cannot do it. It's just a request by 2 of our physicians because you want to verify that the motion is 5 millimeter or less with the chest compression. And breath hold, نرجع to what Dr. Nuha asked me before. Breath hold depends on where you put the box. If we put the box, let's say on location A during CT SIM, and then I got this window during CT SIM, and then during treatment, you put it in a slightly different location, you will be getting different signals. The signals will not affect phase gating. So you shouldn't worry too much about that. You still need to put it in the same location, plus minus, if you're doing gating. But the signal will definitely affect your DIBH window if you put it in a different place, because the way it's moving and the motion it's tracking will be different on different locations of the body. So it's one of the things that we have to pay attention to. Phase gating, respiratory gating really is very involved. Not only you have to do the QA you do for 4D CT, you're making sure the device is using the correct phase and amplitude. And we do this on monthly QA basis. And it's a very simple stopwatch. We use our phones, put a stopwatch, and then we use a ruler. And we have, like a small phantom that we make go up and down, and then we see if what we're getting from our stopwatch and ruler is the same as what the software is recording. However, it's really very tricky to do phase shift, quality assurance on the Linac. And Accuray CyberKnife, where the respiration is tracked, treatment is tracking respiration. That is a more involved end-to-end testing. Okay, do I have the answer? I think I also have the answer. Correct answer is B. Ben, you're good. Today you don't have to worry about any Zoom polling, but tomorrow I'll make sure that I definitely hide all the answers.
It's okay.
So
we can still launch the poll.
If you're already implementing motion management, that's really good. I appreciate that. And your patients definitely appreciate that. But if not, and if you're thinking of implementing motion management, but you only have a limited budget, so the question would be, well, out of luck, sorry, it costs a lot of money. It's capital investment. Or you can ask RCC to donate money or equipment. Then that's for you. Or maybe we could use some life hacks, right? So there's some life hacks that we can do. Okay, so I guess some people will ask RCC for donations. Let's see what happens.
All right, I'm going to give it maybe 5 more seconds and then I'll stop the poll.
Sure, I see 100% answered here. Oh no, not yet, Seth.
Once we get closer to 50. All right.
All right, so thankfully, many people think that we have some life hacks to do. Over 10 people want to ask RCC for donations. Right? And 6 people have absolutely no trust in us because you know what? Motion management requires capital investment. Don't bother. Okay, let's go.
Dr. Ramahi, quick question.
Yes.
They're asking what is the best way to tattoo the patient for setting the ISO? Do you do it on free breathe or normal breathing or deep inhale or deep exhale? Or how does your institution places the ISO center marks?
So we place the ISO center at the 50% phase, and that's done during the CT sim itself. The doctor indicates on the 50% phase, they indicate where the tumor is, and then we have the lasers move to locate that location on the patient's skin. However, we don't depend on skin marks for patient setup for SBRT or any other treatment planning or treatment technique delivery. Skin lasers or skin marks are good for initial setup, but then we are in the era of IGRT, correct? So you set up your patient to the skin marks, but that's not all said and done. You do IGRT localization. However, as you said, we do put some initial marks, and that's on the 50% phase. So location of the tumor on the 50% phase.
Thank you for that. And this question popped up twice. Do you recommend using any medications for regulating the breathing pattern for SBRT cases, whether it's Xanax to reduce anxiety?
I am not a doctor. I'm not a medical doctor. Let's clarify that. So I would refer to the medical doctors, the radiation oncologists in the group. But I have seen some radiation oncologists prescribe Xanax, or, as you said, some other different, whatever is available in the clinic, and the nurses can administer that. So I have seen that done by some radiation oncologists. As a medical physicist, I cannot say anything else, but I have seen it prescribed.
Yeah, it's important. You want to try to have them the same on the day of CT simulation as they're going to be on every day of their treatment. So are you going to give them Xanax every single day of their treatment? Maybe, but more likely you can talk to the patient and try to make them feel more relaxed, understand what it's going to be, and then they feel more comfortable, because once they're in the treatments, once they get to their last treatments, they're probably going to already be more relaxed and be more comfortable. So you want to make them feel that way from the very beginning.
That is correct. So Ben, you have to treat the patient exactly as you have CT sim the patient. And Ben is a radiation oncologist, he can tell you, right? But if you do something for the patient during CT sim, you have to keep on doing it on the different fractionation sessions. So there's some life hacks that you could use if you don't have much, budget to spend in the near future. But definitely, you need to buy some good quality equipment to do proper motion management. First of all, go to your CT simulator, right? If you go to a CT simulator that you bought within the last 15 years, it already comes with its own equipment for motion study. So recently I have consulted for a private clinic that had bought a CT sim back in 2006, and they didn't know that they have already the below belt that you can use to do 4D CT. And they already had the software, and it was part of their, maintenance contract. So basically, if you have a CT sim that you bought in the last 15 years, definitely it comes with its own software to do motion study, to do 4D CT. So let's say you start with 4D CT. You have to, again, find it out on your own CT sim. It's definitely there. And what you could do is take the 10 phases using 4D CT scan, and then you look at the tumor motion. If the tumor motion is 5 millimeter or less, and remember, you're looking at 50% as the baseline, and then you see how much the other phases are moving, depending on the 50% or in relation 50% baseline. If the motion is 5 millimeter or less, then you generate the ITV from all these different phases. You add 5 millimeter to the ITV, and that's your PTV. And you can go ahead and treat your lung patient with SBRT. If it is more than 5 millimeter, RTOG and the AAPM guidelines do not recommend using SBRT if the motion of the tumor is more than 5 millimeter, right? Those are the recommendations. So you can have your own clinical recommendations. As someone who's working in North America and representing an institution in North America, I can tell you if the motion is more than 5 millimeter, the recommendations and the guidelines say we do not treat with SBRT unless somehow we can compress the motion down to 5 millimeter or less. So if you don't have anything else except your CT sim and its ability to give you the 10 phases of 4D CT, go ahead and analyze it. And then you can make a decision, do you want to use the ITV for the SBRT treatment or not? That becomes your own clinical protocol. Let's say you want to take this a step further. Let's say you have patients who you want to treat with SBRT, but they have motion that is more than 5 millimeters. I would recommend the easiest technique for breath hold is maximum expiration, because then, as we've seen, when patients breathe out, they usually breathe out to the same location. And this has been shown by the different phase, different motion study that you do. The 50% phase, which represents the maximum exhalation, is the most stable because most of the time patients breathe out to the same level. Now it becomes their ability to hold this for at least 20 seconds. And you could do, I don't want to make this too trivial. It sure does require a little bit more of physics involvement, of course, but you still need to capture this level of breath hold. Maybe do a homemade box with reflectors and you have a camera and then you need to be able to see it. I cannot recommend that for a homemade device, the therapist press the beam on and off if the signal falls below the window. I cannot recommend that, but I've seen it done. However, I would caution against it, right? So there's some life hacks. 4D CT, definitely everyone can do a 10-phase 4D CT on any CT simulator. And then at least you have evidence-based to the motion of your tumor, of the patient's tumor. If it's 5 millimeter or less, you can use the guidelines for SBRT. If it's more than 5 millimeter, it becomes your own clinical decision, your own clinical protocol. Without spending too much budget, maybe you can have your own breath hold devices that you can create. However, if this is something that you do locally, then you cannot connect it to the LINAC for automatic beam on and off. So there's caution to that. But definitely everyone can do an ITV-based technique. So in summary, motion management is a must for any SBRT program. And what you're trying to do, you're trying to limit tumor motion to 5 millimeter or less. You could have respiratory gating, you could have breath hold, you could have chest compression, or you could have the ABC, the active breathing control that some vendors are selling. ITV, meaning if I take the entire full motion of the tumor, you can use that. However, it is not recommended if you're doing SBRT for motions more than 5 millimeters, right?